Thank you, Dr. Ayman, for this nice introduction. We will just set up the lecture and we'll chit chat, okay? Argument with the other specialties. You know, what is the most important specialties? You know, of course, we are not biased, even though we are neurologists. We will tell you if you lose your mind, nothing else matters. And we will leave you to judge which is the most important specialty. Okay, that's my name. Hamza in Arabic means lion. I did, and this is, I will tell you why I'm going to mention this. I did my medical school in Jordan University of Science and Technology, 1993 to 1999. I did my pediatric training in Texas Tech, and you know, one of my attendings used to call me Hamza. And if those who speak Arabic, you know, Hamza is a lion, Hamza is a whisper. This is the story when a lion becomes a whisper. But I think it will deserve the trial. Now, I did my child neurology training in Ohio State University 2006 to 2009, and then I worked in Des Moines, Iowa, and I moved to UAE. Now, epilepsy. It's the bread and the butter of what we do every single day, morning, night, when you get the call, first thing we think about is epilepsy. What is epilepsy? Epilepsy simply is two or more unprovoked seizures. Okay? Seizure is the event itself. It is a transient, hypersynchronous neuronal discharge that could be associated with the clinical symptoms or might not be associated with the clinical symptoms. Okay? Now, I wanted to look at this video, guys, and okay. So, of course, this is a pediatric, not a geriatric. So, you see what she did? Your only spot and start diagnosis is infantile colic, paroxysmal tonic upgaze, deviation of infancy, Sandy Fire syndrome, infantile spasm, benign myoclonus of infancy. Who cares? All of the above, none of the above. Who's the pediatrician here? I think this is the fourth time you attended this lecture. You are not allowed to answer any question today. Yes, it is benign, but it is benign myoclonus of infancy. Why did I bring that? Because when you have an event, or if you see a patient to bring you an event, the first thing you want to do, you want to know what are you dealing with. Is it a seizure? Is it an epilepsy? Is it not an epilepsy? And where to start and where to go. Okay? If I bring you a broken car and I tell you fix the car, the first question you're going to ask me, what's wrong with the car? You need to know what you are dealing with. A lot of the time, we see a lot of patients, they are on two medication because of sleep myoclonus. He jerks at night. He do this at night. Well, let him jerk all the night. That's not seizure. I see this frequently. I promise you every single week I see these cases. So first you have to, and you must, and you should, and you ought to, and you are due to know what you are dealing with. Okay? I want just to make sure this is clear. If you have a question, always call a friend. Now, diagnosis history from the patient, from the mom, from the dad, of course. In our culture, you cannot trust the mom and the dad because most of the time they are either running or crying or they are lying next to the baby, okay? So we ask for a third person. What did you see? Do you have a video? That is the gold standard for me. That saves my life. I love WhatsApp. Because all the time they can send through WhatsApp. I look at the video and they tell them, you know what, don't worry about it. You know what, you need to see me tonight. Okay? It's very important. Loss of consciousness, did the patient pass out? Sphincter control, tongue biting, post-ictal, was he drowsy, sleepy? Eyes open or closed. In a study, when I was doing my adult neurology training in Ohio State, 95% of people who are jerky or twitching or kicking, eyes closed, this is not epilepsy until or not seizure until proven otherwise. It is absolutely not, 95%. And this is a studied phenomenon. So I always ask the family, when she was jerking or twitching, what was she doing? I'm very close and she was having hip thrust left and right. Okay, or what we call belly dancer gait, then this is not a seizure, man. Sorry, you need to see a psychiatrist. History of spacing off or acting lost. I just say operation, she would walk and she would do like this. You talk to her, you pinch her, you drag her, you throw water. She is absolutely non-responsive. She has complex partial epilepsy. And amazingly, she was seen by other neurologists and they told her, no, that is, don't worry about it, go home. So if you have a question or doubt, give us a buzz. You can find our cell phones and Google, even on Durbizon you can find it, okay? History of CNS insult, infection or injury, and family history is very important. If the whole family is seizing and they have frontal lobe epilepsy, okay, and the kid is doing what the dad is doing, okay, then they most likely has epilepsy, right? Okay? Now, physical exam, always neurocutaneous finding, skin, any birthmarks, what is the head large? We always say the head large, of course, he's smarter, but we have to do more thorough exam. Wood clamp exam, especially in patients with infantile spasm. If does he have a dysmorphic feature? First, when you see a dysmorphic feature, do me a favor, look at the mom and the dad. Because if the mom and dad are, a high achiever and they look exactly like him, that's not dysmorphic. They might look dysmorphic, but they are not, okay? So make sure you look at the dad and mom and decide what is happening. Here you see guys, configurate spot, axillary friction, lesion induced, neurofibroma. Adenomastipation, and green patch, ashy, tumor sclerosis. Okay, now seizure diagnosis. First, I want to do EEG. If I don't have an EEG, would I survive? Of course I would survive. History, and history. I will survive. Why? Diagnosis, EEG help you to classify the seizure, okay? Help in prognosis and guide the treatment, but it does not dictate what you do. There is ectal EEG, patient is seizing, and you have the privilege of running the EEG. That is awesome. That is the gold standard. Or interictal, which is what we get most of the time in between echoes, right? 50% of the EEG can be normal interictal. When the interictal means when the patient is not seizing, can be normal. If you do 3 EEG, and this is, it's a statistics, you can capture up to 85% of people who have seizure. 15% they will never ever have interictal discharge unless they are actively seizing. Okay? So keep this in your mind. I get asked this question but the EEG is normal. What's wrong with her? Well, she has seizure. The EEG helps me, but it does not dictate what I do. MRI, I love MRI. Every now and then they are coming with the new, high-tech things, gradient echo to pick brain bleeding. But if you do an MRI, do epilepsy protocol, especially in the adult, cut through the hippocampus, okay? And long-term video EEG or ambulatory EEG, we hook the patient. We make sure we have a valid address for him because the machine is too expensive. So if he does not bring it back, we'll hunt him down. And we turn on the machine and we report for 24, 48, 72, 96 hours. And I do this not frequently, but I do it a lot of time in my clinic, especially when I'm not sure. Okay, that helps a lot. Then this fancy dandy specs. Now, MRI. I love MRI. I used to hate the radiologist, and I'm sure if there's any radiologists here, because what they do, they put these big boards, and all the neurologists know there is a periventricular high T2 signal intensity. Please consider leukomalacia, or consider leukodystrophy. And I keep running everywhere, calling everybody, sending patients everywhere to find out what's wrong. And so I decided to do neuroradiology and MRI training, and that helped me tremendous to tell the family, listen, I have seen this so many times. Do me a favor and don't worry about it and leave your son alone. Okay? Now, ABC. Every MRI is abnormal until proven otherwise. What do I mean by that? I have to look at the MRI front, back, left, right, up, down, flip it and look at it again. You have to look at every single aspect. And it will be good if you have a template where you can check. Okay? You can look at the brain, and the brain is absolutely normal, and you look at the clivus, and there is, a big tumor. So, and the problem, you can't change the fact, but the MRI, they will always show the abnormality. Now, MRI is trained with its twists and turns, okay? So if you find that abnormality, please rest if you must, but do not stop. Watch it. No visogatiba. This is a different language, okay? Don't stop. Why? Dual pathology is not uncommon. You can have a stroke and brain tumor. You can have a bleeding, or you know what? You can have a stroke and you look at the CAT scan and you have meningeal enhancement. Well, you need to do CSF to make sure you are not missing the tumor, okay? Bias and prejudice are attitude to be kept in MRI. What do I mean by that? If the EEG is abnormal, and the abnormality in the right frontal area, and multiple EEG, I need to look at the right frontal area in more detail. If you have 3 Tesla MRI and you have the right to do 7 Tesla, we'll do 7 Tesla. Send it for another radiologist. But be always biased when you look at the MRI. If I don't look at the MRI, I'm sorry, it is not it. I have to look at every single patient MRI. And I can't tell you how many times we pick up things not picked by somebody else, or we miss things, it's picked up by somebody else. Okay? Now, males and females have equal brain. We all agree on that. And stay safe in the MRI, please, because this is a real story, and I don't think they were using seatbelts. Okay? Now, MRI oath. I swear to God, I will look at every patient MRI, the whole MRI, and nothing but the MRI. Every single resident who was rotating with us, or pediatrician, he has to look at the MRI, and we made the oath for them at Mafraq Hospital in Abu Dhabi. Now, question 2. Question 1. What's the evidence I am dealing with? Is a seizure or not? If it is not a seizure, he's out of my clinic, and we need to find out what is the evidence. Second, is it provoked or unprovoked? We just talked about, subarachnoid hemorrhage, trauma, infection, meningitis. We need to look at why did he have seizure. EEG and MRI, folks, okay? And this is vitamins. It helps you. 50% you will find causes. 50 you don't find idiopathic, okay? Now, unprovoked seizure. I need just to emphasize on this. Unprovoked seizure within 24 hours of a fever is in a patient from, let's say, 5 months to 6 years is febrile seizure until proven otherwise. This is a very, very big misconception. But at the time he was seizing, there was no fever. Was he sick? Yes, but he was febrile yesterday. That's a febrile seizure. Okay? At least this is what I believe, and this is what the literature tells. Okay? Now, I want you to look at this patient, guys. So, first, are we dealing with a seizure? Second, is it provoked or unprovoked? Pediatrician, my folks, what do you think?
During my workout.
You didn't answer. The last time you answered the wrong answer. Okay, that's infantilism. Right? That's where we can make a big difference to the patient. Okay? If you see this, please send them to a nearest child neurologist. Because this is where we can make a big difference. In 1 week, I got 2 patients, 1 4 months late and 1 2 months late, 1 3 months late for treatment, and they both drove me crazy before I was able to control them. Drug of choice, you can answer. High dose cortisone. Okay? So it helps me to know what kind of seizure I'm dealing with. Now, that's the EEG, what we call Hibs arrhythmia. If you look at the EEG this way, or if you flip it over and look at it, it does not make any difference. Do you know why? Because it's high amplitude disorganized background, and it is just like everything is going among each other. Now, what type of seizure? So we said it's a seizure or not, provoked or not, and what type of seizure? Why? Because this helped me with the treatment. Very important. Complex or partial onset seizure, drug of choice prohibited. Don't put him in Dibakine or vitamin D. 99% of the kids come to me in vitamin D. Dibakine. I call it vitamin D. Complex, partial, not complex, generalized, not seizure, myoclonus, what you need, Dibakine and Shipa. This is not the right practice. Partial onset, go with Triliptan, second Kepra, third Lacosamide. Okay? If it's a generalized, then you have the option of going with Kepra, Lamictal, Topamax, and if they don't respond, I will go to Dibakine later on. Huh? So that's help you how to treat the patient. Now, focal onset, secondary generalization, or generalized onset from the beginning. Now, they're simple, consciousness is there, complex consciousness alter. They don't have to pass out. They can be altered, then they can go to secondary generalization. Now, this is our secret weapon, what we call the AEG. That is focal sharps. It disturbs the background, so that is focal onset seizure most likely. Now that is generalized onset, right? You see guys here? The discharge goes everywhere at the same time. So it is generalized, okay? Now, next here. What is this, guys? Dr. Ayman, you love ruins. You're the man for ruins. Roman. This is the colosseum, okay? Here, at the times when the Roman, they used predators, they called them. Predator or predator, they used to fight. Lion against man, lion against lion. Gladiators, lovely. And you have to fight until death. And when they die, you see people lined up here. Okay, they are waiting. And everybody has a cup. Okay? I don't think it's and they collect the blood. Do you know why they collect the blood? You don't answer. Anybody know why do they collect the blood? This was the drug of choice for the falling sickness, the epilepsy at that time. So this is the way how do they used to treat epilepsy. Now, same in which trial? 16th century in America, Massachusetts, if you have epilepsy, you are in big trouble. Okay? They will beat you, they will accuse you of doing witchcraft. And you choose how you want to die. One, you can be burned to death. Here, you see, and this is real. You can be headed, you can be stoned to death, okay? And I think, why? Because they would accuse you of doing witchcraft. And many people, they were killed because they thought they are witchcrafting. Now, treatment principle. I know what's the type of the seizure. I start with the most likely diagnosis, with the most likely medication. Make it simple. Don't make it complicated. When you look at the patient with seizure, don't take, Swayman, like 3,000 pages and put them in your head to decide. It's a very simple procedure. What kind of seizure? Put them in a medication. Make sure you explain the side effect of the medication. It's making them drowsy, sleepy, they might have a rash, and he might, become crazy a little bit, okay? If this happens, give me a call. That all way the complaint. Match the drug for the seizure, please do, and don't use Dibakine for everybody, please, for the sake of God, don't use Dibakine for everybody. And use drug level as appropriate. New anti-epileptic medication with all, I don't do drug levels on it. We have a big review on that and a presentation on that last year. It is not recommended. And if they are adult, make sure you tell them don't drive at least for 6 months. I don't know what's the rule here. 6 months. Please do me a favor, don't drive for 6 months. Even if you forget to tell him that, make sure you document that in your papers. I have explain to the patient that they should not drive for next 6 months, and you sign it and you put your thumb on it. Why? That's a guy walking, all right? This is a lady driving, you can see this in the States, this is, and she must be rich, okay? And in a minute, the guy's flying. This is a real case. The bag is flying, and she's driving, as if nothing happened. And if you go get closer, she was doing like this, and she was going through the green light as for the walker, as if nothing happened. And this was a case of a patient who had epilepsy that's uncontrolled, okay? And she drove the guy, and I think she sent him somewhere or upstairs, I don't know. But if you did not document that in your paper, that is going to be big time against you, or at least it will make you feel guilty that I did not tell the patient that, okay? Now, AED, there's too many AED, I don't think this is the time to talk about them here. And, but you know, remember, Dibakine, Lemictal, Keppra, Tobamax, Zonisamine, they are mainly for generalized onset seizure. Okay, again, don't take a case report or 3 case reports and tell me, listen, but trileptal was used one time in a patient who had refractory generalized epilepsy and it worked. We are talking in general, okay? We are talking about the rule. Partial onset, trileptal, start with that, please do. Second, Keppra, third, go to Lucosamide if it's available. And you know, this is, you know, sometimes we match the patient. If the patient is like 200 kilo and she has epilepsy and she has a headache, I would put her in Tobamax. Okay? If the patient is bipolar or tripolar or quadripolar, depressed, anxious, okay, I would put her in Lamictal. It's a mood stabilizer, explaining that she might have a rash, and that rash might put her in the hospital, and she might develop Stevens-Johnson syndrome again, right? And you don't sign it, okay? If the patient, for example, if she's an adult woman, don't put her in the machine. She will develop a tremor, she will be overweight, she will have hirsutism, may affect her ovary. When they complain against you, they will not tell you, oh, the 200 kilogram made polycystic ovary disease. They will tell, no, the Dibakine was called, ruined their life, okay, which might not be the truth. So make sure you match to the patient. Neelane, phenobarb, phenotone, classical Keppra, I use it all the time. Sometimes Tobamax, I use that. Keppra, avoid the psychiatric patient, okay? If you cannot avoid it, give them the first dose, not the uroclinic, because you need job security. Dibakine, avoid it less than 2 years. Here, the strongly indicated here that everybody give it in 2 years. Above 2 years, below 2 years, okay? It's everywhere used, drive me crazy. Tobamax, overweight, Lamictal, as we talked about that. And other epilepsy treatment, location, just like we explained. If you have it on the right side, you can chop it up. Nowadays we have an epilepsy surgeon here. If you guys don't know about him, we have a top caliber epilepsy surgeon, Brahim Thibeti. He is in Sliman Rahabi. We already did 10 epilepsy surgery refractory patient of mine. We have an excellent response. So if you think he might be a candidate, ship him out to Sliman Rahabi to Dr. Thibeti. If not, keep changing medication. Now, food for thought. Now, the question, are you concerned? Yes? No, I might be, I can be, I should be, I don't know, I'm confused. Who is concerned about what he saw? And the patient, as you guys see, he was on a video EEG, right? Hooked up, video camera in the room, okay? I know, I know that neuron is like black magic. You know what, believe me, you have 50% chance to be wrong. Who is concerned? Hands up. Are you concerned? You are. Who is not concerned? What about this? Neutral? Yeah, it's good. Okay. Now, this is a case of infantile spasm. There was a subtle, did like this, and did like this. On the video EEG, the EEG helped us because you will see an electrodecremental response with that. And sometimes if you do a prolonged EEG, you might capture, the abnormality that you are looking for. I had a patient, we did 40 minutes EEG, it was completely, absolutely clean. 45 minutes, discharge started to come up. So if you did the 30 minutes EEG, don't think you have done every single test for the patient. Okay? If you have in down, do 24-hour EEG. If you are in down, 48-hour EEG. 96 hours EEG. A patient 7 days in the hospital in Columbus, Ohio. Okay? 7 days. On the last day before discharge, because we are not sure what's the effect. He had an attack and it was a complex partial epilepsy captured on the 7th day of video EEG. Yeah, you don't see this every day, but if you have a question or concern, don't let it go and listen to the parents. Okay. Now we always say seizure will hate you, rate you, and shake you. You should shake the seizure, right? And break you, but which neurologist treat you is what makes you. Thank you very much, guys. Thank you. Questions? Non-epileptic seizures, okay? Any other questions? Yes, please.
Just wanted to add one thing. I had one patient with epilepsy. So I was just when discharging, I was just looking at the driving rules. Unfortunately, there is no driving rule here which stopped him to drive. I'm from Canada, so in Canada, if you have one seizure, you are off from driving for 1 year until you have no other episode. But here, unfortunately, the only thing which I could find was 3 months you will be restricted driving if you're found to be some drugs in your system or something, alcohol or anything. But I couldn't find any restriction for epilepsy. Yeah. But anyway, I personally just told him that you should not drive until you've been free from seizures. Until then, you should not drive.
Yeah, in the States, some states 3 months, some states 6 months. But I always, when there is no rule, I apply the last rule I have passed by. So the last rule we used to apply, I was 6 months. So I tell them, please don't drive for 6 months. Fortunately, I don't see many patients over the 18s. I tend to stop around 21 years of age. Okay, and I don't have many of them. But for the adult neurologists or for anybody who's dealing with seizure, please emphasize that. Other questions, comments, concern, compliments?
Thank you.